Good evening and welcome to this live question and answer webinar focusing on simplifying the management of high and low energy requirements in complex needs children. This information is intended for healthcare professionals only. The educational content and agenda of this webinar have been developed by the speakers. The webinar platform, speaker fees where provided, and promotion of the event have been provided by Nestlé Health Science. I would now like to introduce the panel members. Myself is Catherine Simpson. I'm an advanced paediatric dietitian at Central Cheshire Integrated Care Partnership. I've been a paediatric dietitian for over 20 years, initially covering all general aspects of paediatrics, and for the last 15 years focusing on home enteral feeding and cystic fibrosis. Latterly, I have been involved in a research trial looking at pediatric peptide feed 1.5 calorie oral nutritional supplement, where I was the principal investigator for our trust. I would now like to introduce to you my fellow panel members. Heather, over to you.
Hi everyone, my name is Heather Grant and I'm a GI dietitian here in Edinburgh and South East Scotland. My current post covers responsibility for inpatients and patients as outpatients under complex nutrition and liver caseload remit. That includes patients on PN and home PN, enteral tube feeding and liver patients. We often look after patients following a stormy neonatal period right through to transition to adults. Looking forward to tonight and sharing knowledge amongst the panel members.
Thank you, Heather. Next, I'd like to introduce Gemma.
Hi there, I'm Gemma Renshaw. I'm the principal paediatric dietitian and dietetic team lead at Great Ormond Street Hospital, specialising in paediatric cancer and bone marrow transplants. I've been working at Great Ormond Street for over 10 years, with the majority of those in paediatric cancer.
Thank you, Gemma. And finally, I would like to introduce Claire.
You're on mute, Claire.
Sorry, thank you, Gemma. Hi, everybody. I'll try again. My name is Claire Woodland. I work at Alder Hey Children's Hospital, and I've worked there for over 6 years as the dietitian looking after respiratory conditions, specialising in cystic fibrosis, where we manage the network for the whole of the Northwest.
Thank you, Claire. So just a little introduction: nutritional needs and challenges in children with neurodisabilities. Children with neurodisability experience high rates of feeding difficulties with implications for their growth and overall health. Improvement in nutritional status is associated with improvements in growth, motor skills, neurodevelopment status, bone health, and survival. Neurodisability can be defined as a group of congenital or acquired long-term conditions that are attributed to impairment of the brain and/or neuromuscular system and create functional limitations. Children with neurodisability often experience significant feeding and nutritional problems. Feeding challenges include oral motor delay, dysphagia, food refusal, selective eating, and sensory impairment. Gastrointestinal problems can include gastroesophageal reflux, vomiting, food intolerance, constipation, and altered gastric emptying, be that rapid or delayed. The whole range of these challenges provide lots of nutritional challenges for dietitians. The aim of this session going forward will be looking at a live question and answers that you guys have provided in for us to try and give an overview of some of the challenges that this group finds, and really a way of possibly looking at how different members of the dietitians provide different ways of dealing with some of these problems. We will now move over to some of the questions which has already been sent in. So the first question is, what guidelines do you follow for using oral nutritional supplements in neurodisability patients, particularly those with complex needs? I'm first going to open this up to the panel just to see if anybody's got any general questions or general thoughts with regards to this area.
I'll just add in as a general thought, quite often I would go to the 2017 ESCAN guidelines, which gave some really good assessment criteria and management for this patient group. And I would usually start with a very standard fibre containing 1 cal per mil feed and work my way down the tree of complexity as required.
Thank you, Heather. I think one of the other things to bear in mind is obviously it depends on the age of the child. Obviously, it could be very different in what you provide in an under 1 to somebody who's approaching transition over to adulthood. So it's looking at what's appropriate for that child and the stage of their development as well. Anything else to add from the other members? If we then move on to the next question, which has been sent in. Due to delays in gastrostomy placements as a result of the COVID-19 pandemic, how are you managing the needs of children who are struggling to meet their nutritional requirements orally?
I can help you with what we were sort of doing in Liverpool. I mean, we aren't too far behind directly related to COVID. We were probably struggling before then as well. So we're kind of still just managing. We've probably placed a few more nasogastric tubes in the community than we might have done before. So obviously we've got tubes being used nasogastrically rather than just waiting for the gastrostomy. And then obviously for most of them, we are just having to, kind of try and just adjust what maybe is happening, just trying to give them a bit more advice and a bit more support to increase their calories orally.
I think here in Lothian, we've not been too hampered by COVID having too much of an impact. We've had a few lists cancelled, and I think we've just had regular MDTs to kind of re-triage patients on a priority basis and have to manage parents' expectations that actually they might be bumped up and down the list based on patients that then are referred closer, but actually require it more. We've used more nasogastric tubes. I think being mindful, you might have to retry things that previously at an earlier date haven't worked. So retrying medicines or retrying supplements or things that you might have tried in the past that haven't been successful, but that are worth a retry to kind of bridge that gap between either oral diet to gastrostomy or nasogastric tube with issues to gastrostomy.
Thank you. I think that's very common across the board. Mine was very similar. There's been a lot more nasogastric tubes over the last sort of 9-12 months as an option just to keep things ticking over until gastrostomy tubes can be placed. Thank you. If we then look at the next question, which has just come in, when meeting the needs of a malnourished child on feed and oral diet, do you aim to meet all the needs of feed and count oral food as a bonus, or do you count oral diet in the energy provision as it's challenging to see how much they actually consume orally? I think from my experience, it really is very, very individualised. I often will ask families to do food diaries to have a look if that food is just food for pleasure or actually food for calories. And I think you can only ever focus on what is individual to that family. It's very hard to say the calories have to count as something if one day is good and one day is bad. I'm not sure if any of the other panel members have any experience of this.
Yeah, I can answer this one. I mean, within paediatric cancer, it's very common to sort of see this ebb and flow of periods of good eating and poor eating. And so generally what we will do if a child does require some sort of tube feeding support, we will come up with a plan to have meal boluses, if you like. So it might be that we will have 3 or 4 feeds planned for a day. And then if a child eats well at breakfast, you then wouldn't give them the top-up feed, or if they ate half a meal, would give them half of a planned feed, or if they didn't eat anything at all, we'd give them a full feed. So we're able to be quite flexible with the feeding plan. So we know if they don't eat anything, we will be able to provide them with their full nutritional requirements. But then there are other times when a child is particularly unwell, if they're an inpatient in hospital, if they require continuous feeds, for example, if they're experiencing things like mucositis, a sort of an inflammation down the gut, that actually we may go for a continuous feed, meet their full requirements. And then if they do manage anything orally, then in those situations, it would be a bonus. And then we'd reduce the tube feed as their oral intake starts to pick up over those periods. So there is some flexibility and differences depending on the diagnosis and the treatment plan. But that's generally how we manage it.
From my perspective, one of my big patient groups would be the intestinal failure population. So really from birth, they start on 100% PN, and then they would transition to enteral tube feeds, most likely with potentially some oral diet. So they're probably meeting their 100% of the requirements initially enterally, and then we're working back the way, and it starts with tasters, and then when it becomes a bit more consistent, much like Gemma had said in her second scenario there, we start, you know, judging that and reducing down as able. But I probably wouldn't be looking to reduce that down until we were consistently, you know, managing about 15 to 20% of our estimated requirements consistently orally.
Thank you. Anything from you, Claire, to add from that one?
No, to be honest, no, because I mean, I probably work the other way a little bit more, that most of ours are on diet and we're supplementing because of high requirements. So they're probably actually eating a normal diet, and then we're just giving additional calories to sort of from a feed point of view. So I probably wouldn't necessarily be looking at it in quite the same way, but otherwise we would be looking at it the same as everybody else has suggested.
Thank you. We now move on to our next question. What type of oral nutrition support do you recommend for children with short bowel syndrome? I'm going to throw this question straight over to Heather.
Thanks very much. Yeah, when looking at this patient group, I guess we're looking at a group of patients who have reduced bowel length and or quality of the bowel that is residual. So you're looking to maximise your absorption capacity, and also you've got a window of time from infancy until their gut adapts, and when they're about 3 years old. So you've got a period where you're able to really positively impact the prognosis and longer term outcomes of these kids. With that being said, our nutritional goals are looking to prevent further gut atrophy and maximise that process of adaptation that can happen. And to do that, you really have to optimise your ability to feed enterally and minimise your needs to give nutrients parenterally. And you do that by maximising the absorption of the nutrients you're providing, while also ensuring that your food and nutritional requirements are being met alongside that. And quite often these kids have very high nutritional requirements, 120 to 150% of their age or weight appropriate requirements. So looking at doing that, the two things that are really good for adaptation are having the presence of some complex proteins and having the presence of some long chain triglycerides in your feed. The problem of having those present are they're actually some of the things that can actually tip the balance of absorption over the other way and be quite hard to manage. So you're looking at probably a portion of your nutritional supplement being LCT containing, and then the portion to make up the rest of your lipid requirements as MCT. So that's taking the pressure off the gut and maximising tolerance. The other thing I might be thinking about is trying to keep the osmolality of the feed as low as possible, as close to under 450, just to try and maximise the time that feed is spending in the gut and minimise your losses that you've got. You're looking at probably trying to have an energy dense feed, so whether that be a sip feed or, as the question asks, or a tube feed, so that you're trying to give as much bang for your buck as possible with taking the pressure off the bowel and avoid overloading the gut while being able to control losses. So really you're looking at a energy dense, so that's either a 1 or a 1.5 cal per mil feed depending on the age of the child. You're looking at having some complex proteins and some hydrolyzed proteins. You're looking at probably having around about a 50-50 mix of LCT and MCT, and you're looking to keep your osmolality as low as possible. So quite a tough ask to get these feeds to do, but that's the dream scenario for us.
Thank you, Heather. The next question, which we have had come in, is I have a PEG-fed 13-year-old girl who is on my caseload with Wolff-Hirschhausen syndrome, who is weight is on the 50th centile. What guidelines would you recommend to her nutritional requirements as she is allergy intolerant of milk protein? What products would we consider to meet these? I think ones like this are so individualized. It's probably extremely hard to recommend something specific. I'm not sure whether the rest of my panel members would agree.
Yeah, I think, it says there at the bottom that we're looking for an allergy-friendly feed in terms of cow's milk protein. So you're really looking that's probably going to guide the main part of your choice. It sounds like you've got someone that's relatively low weight for their age, but potentially not for their condition. I've not come across someone with that syndrome, so can't comment too much on the specific syndrome. But I guess you're looking to try and work out what appropriate growth, and then work back the way to see what requirements would then help facilitate achieving that growth. And it might be that actually following along that centile for an 8-year-old is appropriate, given that if they've got growth restriction, or actually you're looking at trying to have requirements with some catch up to try and head up the charts towards a more age appropriate requirement.
Thank you. Any other comments from the other panel members? Yeah, I think very much like Heather said, it is very, very individual and very specific, and you just have to focus on that individual child and what they could tolerate at that time. Okay. If we now look at what do you assess a child, how do you assess a child virtually for weight gain or weight loss? I think that's very evident over the last year because of COVID-19, and I just wondered if the panel members could share any of their experiences of how anything could be done virtually in the current climate that we're in.
Hi, I mean, I can tell you what we have done. We're quite lucky that a lot of our children have consistently come into the hospital, so we've managed to have some weights. I did keep a record of weights from home scales for some of the children that I kind of used, almost just comparing them to their own home scales, not necessarily mixing that with the hospital scales, which might have some discrepancy. So if they had home scales, we were asking them to sort of try and keep track with that. And then just sort of general things like, obviously our patients are seen quite regularly. The parents are quite, kind of astute with knowing where they are from a nutritional point of view, what's happening with their weight gain or loss. So, parents are often aware, they're keeping an eye on those things, assessing how well they've been. If they're well, they're still eating well, they're not having any bowel symptoms, then okay, let's sort of presume that things haven't changed. Whereas if maybe they were having symptoms, not well, with systematic for us, obviously if they're having respiratory problems, that might mean that they were then losing weight, and we'd concentrate on that a little bit more. If it's been a bit longer, asking things like, are they still in the same age clothes that they were in before? Are they growing out of those clothes? Are they having, over a year, have they had to buy them new trousers? Have they had to buy them, new dresses, whatever it is? So those sorts of things. And then obviously the BDA have put some guidance out on that as well, which people can use if you're not seeing your patients as regularly.
Thank you, Claire. Anything different that Gemma or Heather have experienced in this last year with regards to virtual such weight and weight loss?
I think I'm similarly with Claire, especially in paediatric oncology, children as part of their treatment, they're coming into hospital regularly. So we've been fortunate in that sense that we've been able to get regular heights and weights for these children. And for those that aren't coming necessarily up as regularly, often community nurses will be going in and have been able to monitor them that way. But like Claire mentioned, the British Dietetic Association have got a whole document on virtual consultations, and there's information about advising about anthropometric measurements and things, which is a really useful sort of go-to guide.
The only thing I would add, which Claire's already really touched on, is really, we think of weight and height as a measure, but actually quite often we can guess what the weight and height is going to be because we know our patients well on just their symptoms. So getting a good assessment as to whether they've still got the same interest in food, how active they are, what are their losses like, are they going to the toilet the same amount of time, are they vomiting more or less, and those things help guide, I guess, how worried I'd be about one of my kids at home. I'm very lucky that I've not really been affected in terms of we've still been able to keep our face-to-face clinics going. Some of my colleagues in our department where patients haven't been coming to the hospital as regularly, one of our support workers dedicated a bit more time to be going out and doing some home measures just by arranging appointments, phoning ahead, doing a COVID check, and then going in and leaving scales on the doorstep. And then there was instructions as to getting some home weights, but with calibrated scales. So that's another way, I guess, of trying to get some accuracy. But we're all just trying our best really through these times.
Thank you. I think that just shows just how we've had to be over the last year. It's been really imaginative at how we can find ways of keeping an eye on these young people's weights. Now, the next one, if we're looking at this, sort of probably affects all of us. If you have a 17 or 18-year-old on a paediatric ward, would you use paediatric or adult requirements to calculate the feed requirements? If I could ask that first to Claire.
Yeah, hi. I mean, I think that on the face of it, if we just sort of talk about just a 17 or 18-year-old generally, I would say if that child is still growing, so if you're expecting that child to still be getting taller, then I would probably be calculating using paediatric requirements. If you think they've then had a static height for a period of time that you don't think they're growing taller anymore, then I would use adult requirements. But obviously for a lot of us, we're actually using specific guidelines with requirements for disease-specific, kind of situations. So for me, I would probably be looking at it from a cystic fibrosis point of view, well, which is subtly different anyway.
Thank you. Heather?
Yeah, totally agree. If they're still growing in height, then I would treat them as a child. And if they weren't, then I would use more adult-based requirements, I guess. In my paediatric population group, the majority of them are vastly, I guess, underweight for their age. So I would say, on average, I would tend to use paediatric requirements way more than I would adults in my practice, because quite often we'd be using weight, age, or a weight for height, plus a catch-up factor, or for their disease state. So varies amongst kids, but I guess it all depends on whether they're still growing.
Thank you. I think it just shows sometimes it's having a look at both and seeing which best fits that child and their current clinical condition. If we move on to the next question, for overnight tube feeding in cystic fibrosis, can you describe your practice for selecting the type of feed and the pancreatic enzyme replacement therapy that you would normally use to go alongside this feed? If I'll throw that one towards Claire.
Yeah, that's fair enough. Thanks, Catherine. So for overnight tube feeding, in the vast majority of patients, we initially start with a 1.5 calorie per ml feed. Unless they were 15 plus, then we would probably use a 2 calorie per ml feed. We'd always use fiber if it was possible. We'd start with a standard feed. We wouldn't use any peptide-based feeds initially, unless they then demonstrated poor tolerance. When we work out requirements for that, we would generally add about 20 to 50% of requirements on to start and then assess it from there. And we would give 40 to 50% of those requirements overnight in that feed, and then presume that they're obviously taking the rest orally during the day. From a pancreatic enzyme point of view, we would work out on the basis of that child's known requirement for enzymes. So if they would all sort of have an amount of enzymes they're taking for fat already, that would be known to us on the basis of their oral diet. So using that number, we would then determine, depending on the feed, the fat content of that per 100 mils to determine, how much pancreatic enzymes we need in total, and 60% of that would be given at the start of the feed and 40% given when they woke at the end of it. And for the vast majority of children, that does work fairly well. Obviously, some not always, and we do have to adjust that, but that's the kind of initial practice, and then we would individualize it going forward.
Thank you so much, Claire. As people will probably notice, we're probably nearly halfway through the session now, and if anybody does have any questions live this evening, please feel free to submit them in. You've got a fantastic panel here with so much knowledge that any other questions that you might have, please feel free to send them in as we're busily going through the questions which have been sent in prior to the webinar going live. Thank you. The next question, which had come in before, is what do you recommend for children with poor tolerance to feed volume? What are your thoughts with regards to overnight feeding in the community? I'll probably start with this one because most of my job role is regarding home enteral feeding. I'm quite happy for home enteral feeders to feed overnight. We tend to avoid that with the children who are NG tube fed just from a risk management point of view, but I have quite a high percentage of children who will feed overnight in the community. It's usually done on a discussion with parents and the consultants with regards to what is going on with their feeds, and if that's part of the parents' actual wishes for overnight feeding. Everyone's quite individual as whether they feel comfortable with being pump fed overnight. Some families that's what they want to do to get the volume in. Others, they don't want to have a medical device running at night when they are asleep. So I'd say it's a very, very individual thing, but it's also based on what that child can tolerate and can you meet their needs. So with some families and children, you actually need to feed overnight in order to meet their nutritional requirements. I don't know whether any of the other panel members would agree with that or have other thoughts on what they think of planning the children for discharge home from the hospital with regards to feeding overnight.
Yeah, I mean, I can add in just regarding sort of the second question to do with the overnight feeds. I mean, the majority of our patients are NG fed rather than gastrostomy fed. And so obviously there's risks associated with overnight feeding with NG. So we tend not to send them home with overnight feeds. If there are specific circumstances where there's just no other way of getting their nutritional requirements in, then we have very sort of deep conversations with the community dietitians and try and decide what the risk is likely to be, and decide together with the multidisciplinary team and the family as to whether or not it would be appropriate for them. But in the majority of cases, we wouldn't send them home on an overnight NG. But for those with a gastrostomy, then we do often use overnight feeds. And if others have anything else to add, otherwise I'm happy to comment on the first part of that question as well.
I'll just quickly mention about the second part there, Gemma, about the overnight feeds. We use overnight feeds a lot, whether it be NG or gastrostomy, really with my patient group, just because we're really needing to make use of every hour in the day, and pump feed really is shown to be helpful in promoting bowel adaptation. So as much as their oral intake is important, we try and get them to orally feed through the day in bolus feeds or some oral diet, and then we do make use of that overnight feed. I guess I'm very lucky to work in an experienced MDT that we do discuss the risk factors with all the patients, but it's probably quite common practice within the GI population to use overnight period for feeds.
Thank you. Claire, anything different that you do from your sort of patient group population?
No, I mean, the same for us. If we're using a gastrostomy feed, unless they've got a reason to not be able to eat orally in the day, we're trying to normalise things for our children. You know, that they're living with something that they don't want to have gastrostomy feeds. It's often that they can't meet their nutritional needs orally. So we would keep them eating and drinking normally during the day, and we just use the overnight to give them the extra. So it would be, you know, the vast majority of cystic fibrosis patients are doing that. You know, obviously it's a bit individual for everybody, but yeah, we would happily use that for gastrostomy feeding. We wouldn't do it with an NG, but again, that's not common practice for my patient group, really.
Thank you, Claire. I'm just going to move back to the first part of that question over to Gemma with regards to the poor feed tolerance. You wanted to add some little bits on that, Gemma? Thank you.
That's no problem. I'm sure others will have more to add as well. I mean, in terms of poor, the question was around recommending for children with poor tolerance of feed volume. And I think within paediatric cancer, it's very expected that children will have side effects of their treatment. For example, things like nausea and vomiting, where they will then have issues with the feed volume. But it's really important to try and tackle the management of the symptoms for us first. So it's worth having that conversation with the families about their antiemetic medications. You know, are they being optimized? Are they actually taking them? And then having a conversation with the medical team in case they need an increased dosage, or linking in with play or psychology if there's issues with compliance. But if we find that actually they are taking as much as they can and actually there's still issues with the feed volume, then if they are on a 1 cal per mil feed, we will then move them onto a 1.5 cal per mil feed in order to give them a smaller volume of the feed, and then try and get in additional fluid as and when they're able to manage it. If there's issues in terms of the feed because of abdominal pain and diarrhea, then it might be that we would actually move across to a 1 cal per mil peptide feed and monitor tolerance from there. I don't know whether others want to give their experience in their specialties.
For me, volume I would normally be going for a high calorie feed anyway, because it's not necessarily about poor tolerance directly for me. It would just be about the calories that I was getting from it. So I would always start with a 1.5 calorie per mil feed if I was going in to use an overnight feed for one of our patients, sometimes even higher than that if they're a bit older. So for us, then volume, it's more about it's not necessarily about poor tolerance to volume, it's about being able to get in enough at a sensible rate overnight. And that's why we would then move to the higher calorie things for us.
Yep, similarly, we would tend to use the high calorie peptide MCT containing feeds. As I said, we do make use of pump feeds because it would be that, or PN would be the alternative. And just making sure that you're really minimizing things that will alter your feed tolerance, whether that be upper motility or lower. So sometimes that could be starting something like loperamide, or starting laxatives if it's the other way, making sure that you have, if you've got pump feeds overnight, then we quite often use farrow bags to try and have a bit of decompression and aid tolerance, adding domperidone to the feed bag, and making sure that you've maximized out your GI medicines like PPIs, or antihistamines can be used for retching, those types of things that might actually all consolidate to add up to pure feed tolerance.
Thank you. Just following on from that, the next question again is really focusing around sort of poor tolerance. So some children with cerebral palsy continually vomit and nothing seems to make any difference. If we're trying to avoid jejunal feeding, is there any advice you would give? Sometimes the vomits are large and mostly effortless posits, but not all day. It's not causing any nutritional deficit, just inconvenience for the family, and the child is not distressed. So really, again, it's sort of a bit of a tolerance issue. Is there anything different from the question before that we'd look to maybe do different when the family or professionals are trying to avoid the jejunal feeding route?
I think in terms of, you're thinking about feed type, you're thinking about feed delivery, you're thinking about position of the child. Sometimes it can be getting them into a good position will aid tolerance, that minimises some of this vomiting, maximising your medicines, putting a farrow bag in, potentially now trying blended diet as a pre-jejunal tube feeding step. And I guess if you're making the decision that you're going to do a trial of jejunal tube feeding, then you're not actually saying that this is you stuck with jejunal feeding forever. You're looking at trying it to see if that aids some symptoms, or sometimes it can create new issues in themselves. So a short period of jejunal tube feeding, if it's appropriate, within then a retrial of gastric feeding while you've worked on other things alongside that. And I think it's really important, if you've got a child with CP, they're likely to have potentially other comorbidities, and actually sometimes it's the chicken and the egg, isn't it? You've got other things going on that can sometimes drive vomiting or retching or feed intolerance, and sometimes making sure that you've had respiratory and neurology and these other teams look and trying to maximise treatment. That in itself, you can be sometimes chasing something in GI that's not fixable, but actually some of the other medicines that can be added in these other specialties really aid the overall picture.
Apologies, didn't want to unmute there. I think that's something I've seen quite common as well, that actually we've tried short-term PEG J feeds just to see if that will actually make any difference, that the family has the option then to just go back to gastrostomy feeds if they are really struggling. And I think it's very much like you said, Heather, it's looking at a bigger picture, and there's lots of different things that can have implications, and sometimes the jejunal route may be the best option, but a trial of it first may be the ideal way to go, just see if that makes any difference. Thank you. If we look at the next question now, in some children who are solely tube fed, it might be complete, the feed might be complete in terms of calories, protein, vitamins and minerals. However, it can often be low in electrolytes, in particular sodium, chloride and potassium. How do the panel manage this? Do any of you recommend using oral rehydration solutions for flushes? And if so, is there any recommendations for this? I appreciate it can be very specific depending on the clinical conditions that you look at, but if there's any experiences you have to share.
I'll just talk about my GI experience, and I'll start by answering the end bit. I'm not aware of any recommendations, no. But within my experience, a lot of my patients, because I've managed them on high energy feeds in order to try and maximise your tolerance, you've still got to make sure they meet their fluid requirements, and quite often they can be short on sodium and chloride and potassium. In particular, if they're vomiting, or if they're jejunally fed and have gastric drainage on, or if they've got a stoma and have losses that we're measuring, then these can be quite high losses, and they're not just losses, they're rich in electrolytes. So I would commonly use diurolite as part of my feed plans, whether that be mixed with a feed volume, and whether that's delivered via the pump or as flushes, as this question asks. And my usual starting point would be to calculate what shortfall there is, certainly to the LRNI of the child, but if not, then the RNI as a starting point, and work your way up from there. I guess we are doing nutritional bloods on these patients. We're checking things like urinary sodium, we're checking their growth, and quite often they bob in and out of hospital where fluid balance is being checked. So it's not necessarily a fluid balance issue, but actually I use it quite commonly, yes.
Thank you. Anything else from Gemma or Claire to add?
I mean, probably not so much from my end. Generally, our patients are managing some oral intake on top of it, so are not solely tube fed. So we tend to be, I suppose, slightly less concerned that they're not going to be getting everything that they need if it's not supplied from the feed.
And the same for me. Most of mine are taking something orally, but for the few that we do have, we would use diurolite in the same way, often mixed with the feed to make up deficits, or like you say, if it's to make up fluid requirements, we would use it as orally flushes, or kind of running that's depending on how much of the pump you're using. So yeah, we would do the same.
Thank you. So if I can then ask the panel now, in your experience, has it been common that children with complex needs on enteral feed, whom are meeting the zinc requirements within the feed, often have serum low zinc levels? I just wondered if any of you had any experience of this at all. It's obviously something that somebody has noticed a slight problem with. Don't know whether I could maybe ask Heather first if she has any thoughts.
Yep, so we've got a fairly large caseload of enterally tube-fed children, and we do have a few that have come back with borderline low or low serum zinc levels despite meeting their requirements through their nutritional plans, so much so that our nutrition nurse actually queried it with one of our biochemists recently, and just last week, so it's a very timely question, and his response was that it's a fairly grey area unless your zinc is pretty low, like under 6, that you would definitely need to supplement. Actually, it's quite hard to interpret that. We've got to make sure that their CRP is normal and their albumin is as normal as possible. If they've got very high copper and zinc compete for absorption, so the two of those, I've started kids on copper to sort out their copper, and it's driven their zinc low, and vice versa, so being mindful of that. And actually this biochemist explained that it really depends on the symptoms of the child, the presentation, and whether the child has been fasted or not. And lots of endocrine mechanisms can precipitate getting a low serum zinc. So he was really reassuring that actually, if you're monitoring these kids, if they don't have symptoms, if they've got no specific reason to have a low zinc, I guess zinc is primarily absorbed in the small intestine, particularly the most part, for the most part, in the jejunum. So I guess if you've had significant gut resection there, then you might expect to get low zincs. But if you've not, then I think it's to be reassured. And he actually indicated that potentially these the assays might be altered UK-wide to account for a slightly lower level of zinc being highlighted as a deficiency going forward.
Thank you. Gemma or Claire, have you experienced any of this in your practice? Might not be something that is apparent so often.
No, it's not something we've specifically come across like in that, like other than what Heather's already said.
Thank you. The next one is a bit of a question for all the panel members. What anthropometric measures do you find useful in your area? So what I'll do is I'll go a little bit around. If I can start with Claire first, and then we'll move over to look at all the different areas.
So in the vast majority of cases, we're just looking at weight, height, length, and BMI centiles. But we do use some mid-arm circumferences for patients with liver disease. And then obviously for our infants, we use head circumference as well.
Thank you, Claire. So Gemma, from a very sort of oncology point of view, any anthropometric measurements that you use different to Claire, or?
So lots of similar ones. I mean, there's literature actually in specifically to pediatric oncology suggesting that no sort of simple anthropometric measure really is going to help identify malnutrition all that well in our patient cohort. So I think it's just really important to look at things as a trend and look at things quite holistically. But we do regularly measure weights just from the ease of it. But it really needs to be taken into caution because, you know, you'd expect a child with a solid tumour will have additional weight. So they might actually seem to be a healthy weight, but they actually might be very malnourished. And then obviously as treatment starts and tumour shrinks or they've had a surgical resection, you would expect weight to drop. So it needs to be interpreted with caution. Similarly, if you've got a child who's being treated with steroids, there might be some fluid retention. So it's really important to look at it in the context of their treatment. But we do use it. We also do measure heights and lengths. But again, it's just to give us a general picture, particularly if a child's had radiotherapy to sort of the craniospinal area, there may be some vertebral loss. So it's things just to take into consideration. And similarly with steroids and bone density. We're also trying to make sure head circumferences get measured, particularly in children under 2, although there is some evidence to suggest that it should be for children under 3 in our patient cohort. We're trying to push that mid-upper arm circumferences get measured to give us a really good sort of idea of what's happening with a child's growth. And ideally, it's not happening, but ideally we would love to be able to do some sort of bioelectrical impedance work because again, there's literature suggesting that there is alterations to body composition and that children who have undergone a cancer treatment have an increased fat mass. So lots of things I think for the future that we're not currently doing, but just trying to make the most of the situation that we've got at the moment.
Thank you. And finally, Heather.
Yeah, much the same. Weights, heights, BMIs. Quite often we'll do mid-parental heights to see what growth potential these kids might have. Mid-arm circumferences are good in patients that you're either potentially tube weaning or they're pre or post liver transplant, mainly pre. Similarly, then testing for your population and skin fold thicknesses, where you've got your WHO growth charts to plot that on for up to 5, and then your slightly older ones that go up to 18. They seem ancient now, but they still do the trick.
Thank you. Sorry, I'm having problems unmuting there. Now, we've just had a question coming through, which is following on from the low zinc levels. I have a home enteral feeding patient who has a raised B12. Again, the feed was checked, but no one could explain it, and there's no medical reason. Has anyone from the team seen raised B12 levels at all in their patient groups? It might be something which is really specific, and as a team or a panel, we'd struggle to answer that one from.
Yeah, I mean, you do see it in cystic fibrosis patients, but it's related to the enzyme, so it's common for us. But there's an explanation for it. So, you know, I don't know about just standard patients, but for us, it's about their enzymes.
Thank you. Moving on, the next question: what energy and protein calculations do you use in paediatric cancer? So, Gemma, I'm going to focus this one straight over to you.
I presume that one's for me. So for our energy and protein requirements, we tend to just use the EAR for energy and the RNI for protein. Again, there's some literature, some suggest that children with cancer have increased requirements, others suggest they have reduced requirements, others suggest that they have no change to requirements. And I would imagine the reality is that at different stages of their cancer treatment, their requirements are different. So I think until we have some really good literature and good research to look at different diagnoses and different treatment pathways and the energy expenditure at each of these stages, we can't really do much with it. But I think if you're basing it on a sort of general 100% EAR and RNI, and then using some clinical judgment. So if you know there's a child who needs to have some catch-up growth, we could add on, or if you have a child who's an inpatient in hospital and not particularly mobile during that inpatient stay, then it might be that we would aim for sort of 75% of the EAR. So it's a little bit of clinical judgment used in amongst that.
Thank you. The next one is quite a general question. How do you get requirements right for children with dystonia? This might be quite a difficult one to answer because it's probably very individualised. I'm not sure whether the panel could have much to comment on this one at all.
I think just coming back to what I said earlier about, a lot of these patients have a massive amount of medical issues, and just making sure that you've got a proper MDT approach with all the different specialist teams. I guess regarding feed-induced dystonia, you're potentially looking at foregut dysmotility, and I think as a general answer, you're looking to try and get away with as little feed as possible that doesn't cause symptoms, but is still then trying to meet their nutritional requirements. So you're probably looking at low volume, nicely tolerated feeds, and you're probably starting potentially with these kids at some of your more standard requirements, but might end your way on very complex feed plans, looking at different feed plans that you've tried, and probably worked your way through a lot of different feeds. So no magic answer, unfortunately.
Thank you. The next question is a really interesting question. What do you do with those patients who are on very minimal tube feeds but still gaining weight excessively? You're aware of the need to try and meet the micronutrients, but they're having very, very low calorie intakes. And how low is too low? This might actually be, again, quite a one where it's very difficult and very individualised. I'm not sure whether any of the panel have any experience at all on those really low calorie requirements.
I think in children that are being fed with very low energy requirements, where they're gaining weight excessively, you tend to need to have a bit of security blanket where you take it away stages and you see the weight still continuing to come up, and yet suddenly you end up on very low feed volumes. I think it's just really important that you're closely monitoring these kids with nutritional bloods, that you're potentially looking at changing feed at some point. If you've started on a feed and you're having to reduce the volume, actually potentially it might be that you have to move to a less energy dense feed. There's feeds that are now available to us that are hydrolyzed feeds that are less than 1 cal per mil, or you're looking at potentially adult or higher weight appropriate feeds with but a much lower volume, and then you're supplementing with things like diorolite and potentially solutions that have got micronutrients in them to supplement. So a very general answer, apologies.
Thank you. A very similar question has just come in now, which is, do you sort of aim for reference nutrient intake for sodium, potassium, chloride and magnesium, as multivitamins are often quite low in electrolytes? So again, I suppose from a panel point of view, it's all very, very individualised. I'm not sure whether anybody has very specific things on meeting nutritional requirements, especially electrolytes, which was more or less sort of what you answered before. I don't know whether there's anything for anyone to add. Probably not. If we then move on to the next question, a child's energy requirements are 50% of the EAR. What do you consider around meeting their protein intake in relationship to trying to meet EAR safe intake when unable in sterile feed? Sorry, I read that a little bit wrong there, I apologise. So a child's energy requirements are 50% of the EAR. What do you consider around meeting their protein intake in relation to try and meet their EAR safe intake when unable within a sterile feed?
So I guess just two things to note from me. I think a starting point in terms of I would never like to go below minimum safe protein requirements. So that would always be a starting point to try and not go below. when my feed choice, I'm looking at protein energy ratio. So although they might have low energy requirements, it's still really important to make sure that they've got sufficient protein to lay down lean stores. So I think you've got your absolute quantity of protein that you're aiming for, and then you've actually got what you're feeding and making sure that what you've got of that is an appropriate protein energy ratio. And I think as much as we'd like to keep these feeds as sterile as possible and not adding, sometimes you end up, you do have to add protein modules to these feeds in order to ensure they're getting what they require. If they've not got any oral intake, whether if they've got tasters or if they've got any oral intake, then you can make use of that as well to make sure they're meeting their protein requirements.
Thank you. Anything else from the other panel members?
I mean, you could only just add that a lot of the modules you can flush through, so you could keep the sterile feed and you could just use the modular stuff as a flush, you know, which is what Heather said. Just to sort of add that there are quite a lot of new ones, aren't there, that give good protein in quite small volumes with low calories. So that's just, you know, a way of keeping your feed sterile if you need to.
Thank you. Just a little time check for everybody who's joined in on our webinar tonight. We have about 7 minutes left, so if there is any burning questions that you'd like to submit, please feel free to do that as soon as you can, and we might be able to answer that for you this evening before the session ends. If we then move on to our next question, for children with cerebral palsy, do any of us use specific growth charts or standard charts? For those with very low energy requirements, how do we meet their protein energy ratio and vitamins and minerals? I know personally I don't particularly use any specific growth charts within cerebral palsy. I don't know whether anybody does anything different. It's probably that we use more the standard ones and really just look for optimizing growth. I don't know whether any of you have any comments with regards to meeting protein energy ratio and vitamins and minerals. Probably follows on a little bit from the question before. Nope. If we then move on to our next question, so how do we interpret growth charts in children with neurological impairment without causing excessive weight gain? Is BMI age acceptable? Some children may drop a percentile over the years, and do we think that that's acceptable and okay? Is it okay to potentially compromise a child's growth and feed to the lower end of estimated requirements in order to keep the child comfortable and have no side effects from the feeding regime? So probably quite a complex question, looking at lots of things really. Does growth, should we affect growth in order to prevent excessive weight gain? I don't know whether any of us have any experience from that point of view.
I guess it would be reassuring to see them still go through puberty at an appropriate time, to consider potentially other anthropometry that would give you reassurance that actually they're not drifting away. And I think with a lot of conditions now, they're progressive. So actually, although they might be drifting away from the centile chart, which is very important to monitor, it's important to kind of tie that together with the disease state that they've got. Sometimes that's appropriate and sometimes it's absolutely not. In my patient group, a lot of the time it's not, but I guess I'm just throwing out there, actually there's some conditions that you certainly wouldn't want them shooting up or down the centile chart. So trying to get consistent growth.
Thank you. Any other comments from Claire or Gemma just before we close on that question, because that tonight will actually be our final question, looking at the time.
I mean, I was just to throw in, I mean, it tends not to be so much in my patient group, but I guess you need to consider what your nutritional aims are for the child. And actually, you know, it might be that growth is the priority, but it might be, like Heather said, that actually getting them through puberty or making sure that they're comfortable with their feeds. You know, there's a whole different level of, you know, there's lots of different elements that you need to consider as part of our dietetic assessment. So it's almost a case of trying to decide and prioritize what the nutritional goals are for the child.
And I think revisiting that every year or every couple of years, however often you see this child, you know, just revisiting what are your short, medium and long-term goals with this child, both medically and nutritionally, and that might just help focus your mind about what you can realistically achieve, but also within the wishes of the family's expectations, quality of life, all of these things, much like Gemma said.
And any last comment from Claire at all?
No, I wouldn't have anything to add than the others have said, but you know, like you say, I think you do have to think about what the child's, you know, I think it is appropriate to potentially compromise growth if that's in the best interest of the child, but obviously it does need to be individual, doesn't it, and appropriate.
Thank you, and just bear with me. So thank you everybody for attending. That is our final question for this evening. If anybody has any further questions that we've not had time to run through this night, you're still free to send those in. Playback will be available through the original registration link for 1 month, and recordings of this session tonight will be uploaded to the Nestlé Health Science Education platform, the N+ Hub. Please can everyone who has joined us tonight complete the feedback questionnaire. A link will be sent after the webinar. Certificates of attendance will also be distributed by your local sales representative and later available on the N+ Hub. Thank you so much for joining us this evening.